So I'm going to be focusing on the issue of the surgical lung biopsy. I'll also allude, the previous speaker already talked to you about the issues associated with surgical lung biopsy as well as the cryo biopsy. And the questions that we had in the guideline did address these issues, and I will touch on that as well. But I wanted to get you a feel for how the guidelines are really done, and it's an incredibly robust way of how the methodologists really look into every evidence that is present to date at the time of when the committee meets, and they synthesize the data incredibly well and then discuss it with the committee. And then the committee makes a recommendation for the specific questions. So what we call in the methodology, based on the Institute of Medicine, there are questions that we ask specifically. Every word in that sentence question is important for us to answer the question. These are called PICO questions in terms of the population and comparators and outcomes. So these are standard thing called PICO questions, and so PICO questions are pre-specified, and we come up with the questions, and normally the institutions of medicine and robust way of grade methodology, they only insist on no more than 5 to 6 or maximum 7 questions to be addressed. And in terms of IPF diagnosis, it's beyond 7 questions. So therefore, those of us who are appointed by the major respiratory societies, you can understand how much of a effort that we'll have done in terms of the questions that we pose. So here we are. So Seattle is when it's pretty day. So my task is bridging the recommendations, okay? So I'm glad that many of you are familiar with these two documentation, but suffice it to say that idiopathic pulmonary fibrosis is, as you well know in this group, that it is in this spectrum of the broad category of interstitial pneumonia or interstitial lung disease of unknown etiology. So unknown etiology, yes, it is idiopathic, but that doesn't equate to the diagnosis of or the clarification of idiopathic pulmonary fibrosis. But the issue is how do we characterize or rule out other aspects. So these are my disclosures in terms of me being privileged as a consultant for many pharmaceutical companies to design these studies. I've also got some research grants, and above all, I am a long-standing patient advocate and also advocate of clinical investigations. So these are 3 things that are going on. Actually, there is a Fleischner white paper that is actually came out in 2018 and our guideline, and then there is another one that the ERS is having a consensus group, but there is really nothing much has been published after that. So the update of the 2011 guidelines, it is a 2018 guideline. So the diagnostic position is obviously important for us for making the recommendation, especially when 2 antifibrotic and more antifibrotic treatment are going to be available for patients with IPF. So we thought in 2011 when we made the guidelines, we thought we'll be a little bit more clear to give a little roadmap to the community physicians. It turned out that there were a lot of screen failures, so we learned a lot from the 2011 guidelines, and therefore there are potentially many patients who were out there with idiopathic pulmonary fibrosis but didn't really meet the criteria, or whether the community physicians or the site investigators didn't understand what we wrote, and so therefore we thought that this is appropriate to update the guideline, and so that's the gist of it. So I won't go over that, just to give you a feeling that this committee has been appointed by the major respiratory societies. The proposal goes in about 50, 60 people, and then the committee, the leadership goes into the portfolios, all the conflicts of interest, and then they pick and choose who the committee members are. So therefore, and for whatever worth it is or not worth it is, I was a privileged chair for it. And so this is in North America, Europe, Mexico, Japan, as well as we took expert advisors. We wanted to get input from the rheumatologists and genetic people and surgeons and such. So these were all the advisors that we took so the methods, I said, guidelines developed in accordance with the criteria, evidence synthesis, I told you what we do, and then appraisal recommendations and discussion, then we talk about it. One of the most confusing part that has come to my attention as a person who's been involved with guidelines and over the last 15 years have become somewhat of a quasi-methodologist by having been dwelling with the methodologist. It is extremely important because the Institute of Medicine brings into these 2 things. One is called a strong recommendation, and the other one is called conditional. Before 2018 or before 2015, we used to call it a strong and a weak recommendation, and a weak for or a weak against. So that caused a little bit of confusion. So I approached the ATS and said, look, guys, this is ridiculous. Let's get it a little bit better way. Then they introduced the word conditional, and it turns out that the conditional is becoming a more pain in the neck than what they intended to be. And in non-English speaking countries, so to speak, they just simply do not understand what conditional is. That they take it for face value. Conditional means, yeah, it's recommended. So the other part of the things that you guys have to understand, when the guideline committee makes a recommendation, it is a recommendation. When we are ambivalent about it, we say it is suggestion. So it's like, for example, we use the word recommendation very loosely in day-to-day life. I might ask my friend and say, okay, I need to go to a restaurant today. What do you recommend? It's based on his or her chance, and so that's right. So it's not that much of an easy term in terms of recommendations concerned. So there are some really strong emphasis on what. So strong recommendation would be is basically what it is. If it is strong, for or against, you just do it, basically. Don't ask questions about it, and just do it, is what it is. But on the other hand, if you don't do it, we are willing to tell a colleague that he or she is wrong if you don't do it, or if you do it, or if you don't follow the strong recommendation. Let's say, for example, the prednisone azathioprine NAC story, okay? So the Panther study came, and so if you still think that it just works and then you're going to prescribe that, that seems a little bit against it. So that's how strength of the strong recommendation for or against is. If, on the other hand, is conditional, it is a correct course of action for majority, but you need to slow down, think about it, discuss it, and bring in the patient, and this is where the patient preferences and your comfort zone is going to be, and this involves a lot of discussions. So that's what is conditional is, and not willing to tell a colleague is okay not following, it's a matter of style, and that is equipoise. So that is basically what the conditional recommendation is, but unfortunately, people who browse, glance, read, even if they read it, they don't understand it, and they just disregard the conditional, is what my experience has taught. And these are the implementation for what it means for the patients and what it means for the clinicians and policymakers. So again, I'll focus on the surgical lung biopsy part of it, and these were the 5 or 6 questions that we were asked or we posed, and the methodologist posted, let's go to and there is an emphasis on multidisciplinary discussions. All right, the guideline is written not for every patient with interstitial lung disease. The guideline is written for a typical patient that we think is going to have IPF. So that's one of the things that the front thing is, this guideline is for a patient that we think is suspected to have IPF. And the suspected patient have IPF is well known to you now, is a male predominant disease. But on the other hand, rarely patients manifest acute exacerbations, and that could be an acute presentation. And even though we said that the typical patient is 60, but in this new guideline, we said, well, if it's a 42 or 43-year-old person and happens to have a strong family history, then the presentation may be typical to the 60-plus-year-old gentleman, and so therefore, that would be a typical patient as well. So the diagnosis of IPF requires that basically exclude the causes and presence of CT pattern of UIP and then a specific combination. So therefore, it demands us as pulmonologists to interact with the radiologist to understand what this UIP is. And once you have that UIP pattern impregnated in the mind of yours, when you approach a patient, therefore, you're going to be putting in that contact in the right clinical situation. So in 2011 and 2018, so we brought the issue of the bronchoalveolar lavage back into the 2018 guideline. 2011, we said not really needed for a patient who is suspected to have IPF, and we emphasized the MDD, or the multidisciplinary recommendation, and it should take place after the CT or even before. So this is the 2011 guideline. We made it very simple, identifiable cause, ILD, and if you have a CT, UIP, don't bother about discussing, and that's about the end of the story, is what we said in 2011. In 2018, we said, well, you have a potential cause or condition, then re-look at the evaluation of the CT scan, talk it over with your radiologist, and then if you have a specific diagnosis of an identifiable cause, let's say connective tissue disease, or if it is bird exposure or something of that nature, it's not IPF, then it becomes into a category of this probable UIP, indeterminate, and alternate diagnosis, where you need to make a discussion with your radiologist and everybody to see whether we need to pursue a diagnosis through a lavage or a surgical lung biopsy or a cryo biopsy now. So this is basically the key update is the issue of the bronchoalveolar lavage, as well as the multidisciplinary discussions at all levels. So then you consider a surgical lung biopsy in an extremely appropriate situation. So again, we recommend a detailed history. Again, this was a recommendation, as I said. We recommend a surgical serological testing, and we recommend not measuring the biomarkers for the sake of circulating biomarkers, that is, for the sake of making a diagnosis specifically for IPF. So you are familiar with this. I'm not going to go over with this because this is the 4 patterns that we describe in terms of the UIP pattern, but you really need to know what we're talking about. But the issue of the probable UIP comes in terms of the diagnosis is concerned. So probable UIP, this is the images with the UIP pattern, demonstrating the honeycomb pattern that you know is the lower lobe disease, and then you have a probable, you still have the lower lobe predominant pattern, but then you do not have honeycombing. The probable UIP has the distribution identical to the UIP pattern with the honeycombing, but the probable UIP has got no honeycombing. Some people will argue that this is honeycombing, but then if you look carefully, it's actually traction bronchioloectasis. It is a cross-section of the bronchioles closer to the periphery, giving you a false impression that it is a honeycomb pattern. So then there are indeterminate for UIP pattern. That means we cannot know whether it is a UIP. It could still be. And this is what we had possibly called it as a possible UIP in 2011. Again, the distribution is all the same. It's still the lower lobe, but this doesn't have any bronchiectasis, no bronchioloectasis, no honeycombing. The distribution is still lower lobe, but it's just reticulation, and some of us would prefer the term called it early UIP. So the CT patterns, then if you have alternate diagnoses such as cysts and ground glass and all of that, you don't make a diagnosis of UIP pattern, and shown here. And that is also the air trapping on the exhalation that raises the probability that you're dealing with a hypersensitivity pneumonitis part of it. All right. So this is the alternative diagnosis. Of course, if you have a dilated esophagus and other features to suggest that you're dealing with a connective tissue disease, like dilated esophagus, clavicular erosions, then you're making a diagnosis of a likelihood that it is a connective tissue disease-associated UIP. So the issue now, the surgical, this is the question that, again, I told you, with the PICO questions are specific. Now just bear with me the attention of 4 patients with newly detected ILD of unknown cause and who are clinically suspected of having IPF. Should surgical lung biopsy be performed to ascertain the histopathology diagnosis of? So every wording is that, it's the histopathology. So the discussion was held, and then the committee discusses a lot about for maybe 45 minutes to an hour after the evidence is synthesized for us. And then it weighed the downsides for most patients, and the recommendations were for patients who have a CT pattern of probable UIP or indeterminate or alternating, we suggest. This is where I say we suggest. We never said do it. This is the thing that has been taken out of proportion, and the Europeans saying, well, guidelines said do it. But we never said do it. We suggested for patients who have CT pattern of UIP, we recommend not doing a surgical lung biopsy. And that is important to understand why it is a suggestion and why it is a not recommendation. This is a nice paper done by John Hutchinson and group. These are actually from the United Kingdom, but they looked over with the database in the United States and then gives us an important feature of the risks of mortality. If you do an elective patients and non-elective patients, the mortality rates is very low, but the low is about 1.7%. If you do an urgent surgical lung biopsy, such as a person who is having acute exacerbation or risk patient, the mortality rate is quite high. So this is an important variable that has to be taken into consideration. So surgical lung biopsy is not indicated in the highest risk patient. And this is written very precisely in the document. For some reason, I don't understand why people don't read it, and if they do read it, they don't seem to register it. So we have clearly said do not do it in those patients who are at high risk. And surgical lung biopsy may be unnecessary in some familial cases. So the panel has no recommendation against conventional transbronchial biopsy. So we looked into whether transbronchial lung biopsies were done and such, and so cryo biopsy, we made no recommendation at the time when we wrote the guidelines based on the evidence to date then. So for patient summary of the recommendations for the guidelines, it really is it depends upon what the CT pattern is. So if your CT pattern is probable UIP, indeterminate, or an alternate diagnosis, we suggest the following. You could do a bronchoalveolar lavage, we suggest a surgical lung biopsy, but the panel made no recommendation of whether to do transbronchial lung biopsy or cryo biopsy. It made no recommendation means that it doesn't mean don't do it. It doesn't mean do it either. That means you discuss it, you look at the data, you formulate your own opinion, see what the evidence is and such. So that is what, at least based on the recommendation, the committee could not come up with a recommendation based on the consensus. And that is basically how these are transparently disclosed in terms of how this committee wrote the recommendation. So for patients, again, with the same scenario, we suggest not performing. This is a person with having UIP pattern, and you have excluded the connective tissue disease, and you have done all the environmental exposure history. So we suggest not performing the lavage, because some people in Europe would argue, even if it is, then I would want to know if it is a lymphocyte, which raises the probability that the UIP may be chronic hypersensitivity pneumonitis. We recommend not performing surgical lung biopsy, which is a strong recommendation for the person with the UIP, and the evidence was low, but it was a strong recommendation. And we recommend not performing transbronchial biopsy for the people with UIP pattern, as well as the lung cryo biopsy. So if you have a UIP pattern, and then you do not need any procedures, is a strong recommendation. That's basically why the reason to know what a UIP pattern is all about. All right, the new guidelines, therefore, we refined the UIP criteria. We eliminated the term called possible UIP. We refined and merged the pathology definitions of the probable or indeterminate and the definite one, similar terminologies. And the new guidelines will emphasize the need for the bronchoalveolar lavage, not the need for lavage, but the need for the multidisciplinary discussions at the time of the procedure decision-making process. So it is hoped that this guideline will really help us as physicians confronted with patients with the interstitial lung disease of unknown etiology suspected to have IPF to make the right decision in terms of the diagnostic approach of whether to do a surgical lung biopsy or other procedures. So that is, and then it will make an important decision in terms of the choice of your antifibrotic treatment or enrolling patients in ongoing multiple clinical trials. All right, so coming back now to the bridge, so either whether we divorce it or we marry them together is between these two documentation. So diagnostic criteria for IPF, for Fleischner Society, unfortunately or fortunately, at that particular time when we were working on the guidelines, I actually did not know that there was an ongoing Fleischner Society documentation going on. So when we met with the committee for making a recommendation, then it dawned on to me because people mentioned to me, and it turns out that many of our guideline committee members were also writing this whole Fleischner's white paper as well. So these two guidelines came more or less at the same time. But then if you look at again, I told you what the guidelines are all about. And what is this? This is actually published in the Lancet in the review section. So the guideline, this is an expert opinion, whereas the guidelines is basically on the evidence base with methodology. This basically is expert opinion of the members of the Fleischner Society that was handpicked and chosen. Then the clinical, then the discussions of the multidisciplinary approach is also emphasized, and then they said that the working diagnosis is an okay aspect, and then see how the disease behaves, and then make a diagnosis. So Athol Wells is one of the leading peer persons in IPF community and ILD community. He wrote a comment in the Lancet Respiratory Medicine and said, well, in summary, the Fleischner Society statement and the joint guidelines are broadly concordant. So then we were asked to write an editorial, or write more or less in the same month. All right, Ganesh and Luca and Kevin Wilson, who is the project leader for the methodology, will try to help the community readership in terms of how do you bridge it. Is there differences in it? Because at that point it became, well, Fleischner says don't do the biopsy, guidelines says do the biopsy. So look at this, in terms of the comparison is concerned, I told you the number of authors were overlapping. 8 people wrote the same documents. So therefore, it is not surprising that there were very similarities. But the evidence-based approach based on the highest Institute of Medicine standard were all in terms of the guideline papers, and then with the exception of expert opinion-based approach, there was some similarity, but this was the institution of medicine standard approach. So it's a little bit robust, if you want to call it that way, for evidence-based guideline. And that then, therefore, begs to the point of who's going to implement in terms of policymakers. In the United States, it's in terms of insurance and such, it's important. So yes, there is no question that the guideline has an emphasis in terms of the implementation in the community as well as the policymakers. But it is unclear whether the Fleischner's documentation is going to be as strong as the guidelines in terms of implementation. The most important so-called differences are in the probable UIP pattern. So clearly, the Fleischner said biopsy not recommended, but that's what it comes out as. And then this guideline, we said conditional recommendation. And then, so the point of this is, it is an equipoise. The guideline panel concluded the biopsy is appropriate for a majority of patients, but may not be appropriate. They indicated a clinical equipoise is what I have emphasized. So then, as that we published that in 2000, about November or so in 2018, but then it became clear to the ATS, because ATS started to get a lot of letters and said, well, the guideline really says it has to be doing biopsies. Do we really have to do a biopsy? And apparently a patient was subjected to a lung biopsy because the guideline said, and then a patient died of the guy, and then it became a major issue. So the ATS then asked me again. He said, well, Ganesh, can you help the community to bridge this? So then this day before this week, November 1, this is published in the Blue Journal in terms of the whether it is mandatory or not. So we said it is not mandatory. So basically what it is the clinical suspicion for IPF. I showed you that if you have the UIP pattern, this is the probable, this is bronchiolectasis, and this is the UIP on honeycombing. We said don't do the biopsy, but for this pattern, you have a clinical suspicion for IPF, don't biopsy after MDD, but maybe for a small group that do the biopsy for a probable UIP, as long as there are no risk for surgical contraindications and surgical risks. So that is basically, we said it's not mandatory, and then as I said, this is just out in the press or in the Blue Journal. So the overriding goal was to help the clinician diagnose for more accurately. Right, the 2018 guidelines make conditional recommendations, and whereas the Fleischner Society indicates that a confident diagnosis of IPF can be made in the right clinical context, which is basically we're studying the same thing in a different terminologies or language. This reflects differences in methodology and terminology rather than any substantial differences and recommended practices. So it is apparent that the recommendations in the 2018 guidelines are subject to misinterpretation as a mandate for surgical lung biopsy and probable biopsy. Avoiding this misinterpretation is precisely why the guidelines said it is conditional, a grading option that was not available to the authors of the Fleischner Society statement. This conditional strength of the recommendation provides clinicians with equipoise to discuss with the patient to forego the biopsy in the right clinical context. If you look at then, if you read the Fleischner's document properly, in fact, this is a quote from the same paper. Surgical lung biopsy remains an important method for the diagnosis of IPF in a large subset of patients who cannot be diagnosed on the basis of clinical and imaging features alone. So I don't think that the document is telling anything different than what the conditional recommendations were made. So I think they were basically telling the same thing, specifically that for the probable UIP, it's use your clinical context and judgment and not mandatory to have a surgical lung biopsy. So therefore, we have a patient suspected to have IPF, and then you have a potential cause, and no, it's not IPF. Then you have a chest CT pattern with probable UIP and all the other categories. You discuss it with the radiologist, discuss it, and then have a multidisciplinary discussion, and per the table that we have given, then you can make a diagnosis of IPF with a reasonable amount of certainty. But on the other situations, well, let's say when there is a remote exposure or mold in the home or something, and if there is some air trapping it subtly, then discuss it with the patient, and then maybe the surgical lung biopsy is an appropriate way, as long as there are no risks for the surgical lung biopsy procedure. So this is basically the table composite that we gave the IPF suspected patient, the CT pattern, and the histopathology pattern. So if you follow the grid, then it is easy to make a diagnosis of IPF. At least we think it is easy to make a diagnosis in the right situation. And when you have an alternate diagnosis, either by the surgical lung biopsy or by the CT pattern, it's not IPF. And then there is a terminology that we use, the word likely. And the likely was if a person has indeterminate, and then if you're going to do a lavage, and if there is a lymphocyte predominant or no lymphocyte predominant, that would be a likely diagnosis. So an indeterminate diagnosis may be reclassified into a more specific diagnosis after a multidisciplinary discussion or additional consultation. All right, so that is where basically I think I've bridged that recommendation. So what evidence now do we have since the guideline? All right, that is an important part of it. Yes, the guideline is there. Is there anything new? And already the previous speaker showed you the cryo biopsy part of it. So what I'm going to do is the guidelines were developed, as I said, using an approach adhered to the Institute of Medicine recommendation. And then there is another approach that we took. This was an offshoot project that we took that asking, well, maybe people started to criticize, well, these guidelines, 25 people that the ATS and ERS and JRS and ALAT recommended, maybe there is another opinion. So we had a concurrent offshoot project going on to discuss about how a person can make a recommendation based simply on expert opinion rather than going through the rigorous of the robust methodology with the methodologists. So this paper is out as well. So the question was, is the need for adherence. Is there a need to adhere to the Institute of Medicine pathology? So what I did with this, when this study was going on, so I approached 25 other experts in the world with the ATS and the ERS, and without them going through the methodology, robustness, just asking them to take a survey, 5 minutes, 10 minutes, and see what the recommendation would be. So the experts who were not on the IPF guideline were selected, and these were the experts away from the guidelines. And these are all matched, if you will, to the expertise and the gender and all of the diversity is concerned. And so the modified core process developed recommendations were in fact concordant to the methodology. So therefore it is yet another proof that in terms of other experts who were not in the committee agreed with the same question that they were asked to answer without the benefit of the robust methodology. So the question is transbronchial lung biopsy. Is there a reasonable alternative to surgical lung biopsy? I told you that there was no recommendation made. So this has already been alluded in the preceding talk, that there is a genomic classifier, the molecular diagnosis of Uip pattern can be made with a reasonable amount of certainty using a transcriptional data. This molecular classification has been published recently in the Lancet Respiratory Medicine, which gives you a feel. Sorry, I don't know what happened here, but that basically tells you the graph that already the preceding speaker showed, the specificity for making a Uip pattern on a molecular classification on the transbronchial lung biopsy was 88%, but the sensitivity was in the 70% range. In other words, if the molecular classification does not say it's Uip, you will miss 1/3 of the time a Uip diagnosis. So there's a suggestion that the molecular diagnosis or a genomic classification in transbronchial lung biopsy might work, but it only tells it's Uip pattern. It doesn't tell you whether it's Uip due to hypersensitive pneumonitis or Uip due to a connective tissue disease. So that really is the next stage of the genomic classification. So using a molecular classification, I told you the specificity and sensitivity already. And then the issue of the lung cryobiopsy. The lung cryobiopsy, I told you that the guideline when we wrote, we could not have, the recommendations was not made or made to do the procedure or not to the procedure. But we also said that in experienced centers and in experienced hands, if they're already doing the procedures, then they're okay to go ahead and do it. So basically we deferred it to the expertise availability in terms, but we didn't make a specific recommendation whether cryobiopsy has to be done or not. Now, after that, this was just on September 30. This data was published in the ERS in Madrid. This is a cryo biopsy versus open lung biopsy. The preceding speaker showed you about the Romagnoli data on the 21 patients with the surgical biopsy correlation with the cryo biopsy for histopathology, which was a poor observation situation. But this particular study is the only study to date, and this is just published in the Lancet Respiratory Medicine about 10 days ago or so, is the prospective data on the cryobiopsy and surgical lung biopsy done in the same lobe, same patient, and then had three blinded pathologists review for the histopathology correlation. So this is at 10 different sites in Australia. It's an Australian study done at the principal investigator, Lauren Troy, and I was actually a privileged member of the steering committee members, helped in the design of the study as well. So the diagnostic accuracy of the transbronchial lung cryobiopsy for interstitial lung disease, a prospective comparative study, has shown, and there is a good correlation in terms of the histopathology correlation by the pathologist as far as paired samples are concerned. So this is the first directly comparative study to show a high agreement between the transbronchial lung biopsy and surgical lung biopsy. No new safety signals were emerged from the transbronchial lung biopsy, and it supports the clinical utility, but it also draws a paragraph of section, a limitation section in terms of expertise, so it's not yet prime time to just release it to the community physician who may not have had the experience with the cryobiopsy. So what do we then do for the guideline is concerned? The guideline was 2018, this is 2019, and need to be updated, obviously, with new evidence. So I've already proposed it to the ATS. They gave me a grief already. Ganesh, you're still trying to help people understand the 2018 guideline, and you want to update another guideline? So you're nuts. So I'm trying my best, but because there is convincing data in terms of the molecular biology, I think you as community physicians and we as physicians as well need to know whether this is going to be a recommendation or not. So I don't know whether, I think you as community physicians and we as physicians as well need to know whether this is going to be a recommendation or not. So I don't know whether these three issues, I think, has to be brought up in a new guideline: the surgical lung biopsy, transbronchial lung biopsy, and the transbronchial lung cryobiopsy. Just to focus on this particular issue for the diagnosis, I think it is appropriate to update the guidelines in a hurry, not as a haste makes waste, but I don't know whether we will be authorized to update this particular guideline right now. The protocol review committees are all reviewing it, and if it is a go, then we will have a new update hopefully next year. So in the interim, it's a dynamic interactive process with an internist, pulmonologist, thoracic surgeon, radiologist, and including the rheumatologist. And that's basically what the guideline and the recommendations are based on the Fleischner document and the current status. So I'd like to acknowledge all the investigators worldwide and patients without which the data would not have included, expert advisors to write the committee, and the ATS and the ERS and JRS did a very good job. Community pulmonologists, you were invested interest in the patients as well as partnered with us, as well as this particular document methodologist guru, if you will, at the ATS. It's called Kevin Wilson, who helped us out to navigate this methodologist to make sense to the clinicians who are not trained as methodologists. Thank you very much.